Imagine stepping onto the cardiology ward for the very first time. You are surrounded by the frantic, high-pitched beeping of monitors.
Oh, it's totally terrifying.
Right. There are nurses rushing past you, holding clipboards, attendings, firing off orders down the hall, and everyone seems to be communicating in this rapid-fire dialect made entirely of three-letter acronyms.
Yeah, it really is the ultimate trial by fire. You step out of the quiet safety of the medical library and right into the actual trenches.
Exactly.
Suddenly, all that abstract theory you memorized just evaporates when a senior resident turns to you and demands a progress order, right this second.
Well, welcome to this deep dive. Today, we are unpacking the ultimate survival guide for medical students, externs, or, anyone insanely curious about how hospital medicine actually operates behind the scenes.
For sure.
We're going to break down the critical medications, the unwritten rules of the heart ward, and specifically this list of 50 must-know vocabulary terms that you need to master before you even set foot on the floor.
Yeah, the stack of sources we are pulling from today is incredibly practical. We are synthesizing official Thai Heart Association guidelines for acute coronary syndromes, academic nursing texts focused on ECG interpretation.
You're so dense, by the way.
Oh, incredibly dense. But we also have some fantastic pharmacology cheat sheets and real-world survival guides specifically written for that Extern 101 experience on the front lines.
Our mission today is to shortcut your learning curve. We want to get you to the point where you can walk into that ward understanding both the hardcore cardiovascular science and, those essential soft skills required to thrive.
Right.
So whether you are prepping for your actual clinical rotations or you just want to decode what the doctors are yelling about on your favorite medical drama, this deep dive is custom tailored to get you fluent fast.
Fluency is actually the perfect starting point. The Extern 101 source is super adamant about this. There are roughly 50 must-know vocabulary terms you just have to internalize.
Yeah, 50 terms, yeah.
Yeah, before you even look at a patient, if you can't speak the language, you are essentially a tourist in a really high-stakes environment.
Looking at those 50 terms, it feels like an absolute alphabet soup. Every location, every document, every staff member is just reduced to a code.
Totally.
Like you start out at the OPD, the outpatient department. If a patient's condition deteriorates, they bypass the standard IPD, the inpatient department, and get rushed to the ER.
And from there, they might end up in the ICU or, the holy grail of this specific rotation, CCU, the coronary care unit.
That's just the geography of the building, right?
Right. The real complexity begins when you pick up a patient's chart.
Right.
You have to decipher the patient identifiers, which are absolutely critical.
Yeah, the sources outline the big three, HN, AN, and VN. The HN is the hospital number, which acts as the patient's permanent, lifelong identifier at that facility. The AN is the admission number, generated specifically for that single hospital stay. And the VN is the visit number, used mostly for outpatient encounters. But I have to wonder, in an era of digital charting and barcodes, why does an extern need to have these memorized so rigidly? Isn't it just saving ink?
Well, no, the stakes of mixing those up are surprisingly high. Let's say you are writing an urgent progress order for a heavy blood thinner like heparin.
Okay.
If you enter it under the patient's permanent HN but fail to link it to the current AN for that specific admission, that order might just float in the digital ether.
Oh, wow.
Yeah, the pharmacy doesn't see it tied to the current bed. The RN, the registered nurse, doesn't see it on their immediate task list, and the medication gets delayed.
So you could theoretically be prescribing a lethal dose of medication to a ghost in the system.
Exactly. It's not about saving ink. It's about building this hyper-specific coordinate system to prevent catastrophic errors.
That puts it into perspective. And you have to communicate those coordinates to the right people. You mentioned the RN, but the guide also lists the PN, the practical nurse, and the ONA, the nursing assistant.
Right. Knowing who executes which type of order is just as crucial as writing the order itself. A huge part of ward survival is recognizing that the nursing staff runs the ecosystem.
They really do.
The doctors dictate the medical plan, but the RNs and PNs operationalize it. Communicating precisely using this standardized vocabulary is how you advocate for your patient.
Because if you write a sloppy order, the nurses will catch it, but it creates friction, right?
Exactly. It creates friction and it delays care.
So, okay, once you understand the geography of the CCU and you can read the alphabet soup on a chart, you inevitably have to look up at the machines actually keeping these patients alive.
Yes.
The centerpiece of the cardiology ward is the ECG, the electrocardiogram.
The squiggly lines that dictate everything.
Literally everything. But before we even get to diagnosing a heart attack, the nursing texts break down the biological division of labor happening inside the heart to create those lines.
Right, it's not just one uniform muscle flexing.
No, the sources divide the cells into 3 highly specialized groups. You have the pacemaker cells, like the SA node, acting as the spark plugs to generate the electrical impulse. Then you have the electrical conducting cells, like the Purkinje system, which are essentially the copper wiring carrying that signal.
And that wiring delivers the spark to the myocardial cells, which do the actual physical labor of contracting.
Okay, so the ECG is showing that process.
Yeah. What you are witnessing on the ECG paper is the electrical journey of that spark traveling through the wiring to trigger the muscle.
So when that electrical journey gets interrupted by a blockage, or, the muscle tissue itself gets damaged, the wave of electricity has to detour, and the squiggles change shape.
And that change in shape is the definitive marker for diagnosing an ACS, an acute coronary syndrome.
Which is a huge deal.
Massive. The sources draw a hard line between a STEMI, which is an ST segment elevation myocardial infarction, indicating a complete arterial blockage, and an NST ACS, where the blockage might just be partial.
And the Thai Heart Association guidelines treat the ECG with extreme reverence. They highlight an absolute mandate, like an ECG must be done and interpreted within 10 minutes of a patient arriving with chest pain.
That 10-minute window is completely non-negotiable. In cardiology, the foundational rule is time is muscle.
Time is muscle, wow.
Yeah, for every minute a coronary artery remains occluded, myocardial tissue is undergoing irreversible necrosis. It's dying.
Here's where the clinical guidelines get really interesting to me. We typically imagine an ECG as a standard 12-lead setup, right? Like stickers placed on the exact same spots on the chest every single time.
Right, the standard view.
But the guidelines state that if you suspect a posterior wall myocardial infarction, you have to physically move the leads to the patient's back, positions V7 through V9, or if you suspect a right ventricular infarction, you move the leads to the right side of the chest, V3R and V4R. Why are we suddenly moving stickers around?
Well, think of a standard 12-lead ECG like looking through the front windows of a house. You get a fantastic detailed view of the living room and the front hallway, which corresponds to the left ventricle and the anterior wall of the heart. But you have zero visibility into the backyard.
And the left ventricle usually gets all the attention because it's the massive workhorse pumping blood to the entire body.
Exactly.
But if a patient has an inferior MI, meaning the damage is on the bottom of the heart, the guidelines dictate you have to go look at the backyard to check the right ventricle.
You have to.
Because I'm looking at the anatomy here, and if the right ventricle is infarcted, it loses its ability to push blood forward into the lungs, which means blood isn't making it to the left ventricle to be pumped out at all.
And that cascade is exactly why the right ventricle is so special. It is heavily preload dependent.
Preload dependent.
Yeah, it needs a massive volume of returning blood to maintain enough pressure to overcome the damage and keep pushing fluid forward.
Oh, I see. So if a patient with an injured right ventricle complains of chest pain and you just give them a standard everyday nitrate medication, which dilates blood vessels, that actually reduces the volume of blood returning to the heart.
Yeah.
That feels like a disaster waiting to happen.
It is strictly contraindicated for that exact reason. If you dilate the veins and reduce that returning blood volume, the damaged right ventricle has absolutely nothing to pump.
Wow.
The patient's blood pressure will just crash.
Yeah.
So moving those stickers to V3R and V4R isn't just a textbook exercise. You are literally altering your vantage point to ensure the routine chest pain medication you are about to order won't send the patient into cardiogenic shock.
And if you miss that right ventricular infarction and you give the nitrate and crash their blood pressure, if you don't correct that crash immediately, you are going to end up facing the ward's ultimate nightmare.
Yeah.
The monitor stops showing those squiggles entirely.
The dreaded code blue.
Yeah. The nursing protocols outline that when a patient goes into cardiac arrest, you're usually looking at one of 2 devastating rhythms. There's asystole, the classic flatline, and then there's PEA, pulseless electrical activity, where the monitor shows a rhythm that looks somewhat normal, but the heart muscle is so damaged or obstructed that it isn't actually generating a pulse.
In both of those scenarios, the immediate drilled-in protocol is to call for help, initiate high-quality chest compressions, and push epinephrine the foot every 3 to 5 minutes.
But the sources make a fascinating distinction here between supportive care and specific care. Like, CPR and epinephrine are just supportive.
Right, they're manually forcing oxygenated blood to the brain just to buy you time. They do not fix the reason the heart stopped.
Exactly. To find the specific care, the protocols provide a rigid diagnostic algorithm, the 6 H's and the 6 T's.
Because in the absolute panic of a code blue, with alarms blaring and adrenaline just flooding your system, your higher level cognitive function deteriorates.
You can't just think on your feet.
No, you cannot rely on organic brainstorming. You systematically run through this framework to identify the reversible cause.
It functions exactly like an IT troubleshooting guide, but, for human physiology. Instead of checking if the server is overheating or a cable is unplugged, you run through the biological systems.
Right.
For the 6 H's, you are checking for things like hypoxia, severe acidosis through hydrogen ions, or massive electrolyte imbalances like hyperhypokalemia and hypothermia and hypoglycemia.
And the 6 T's force you to look for physical or chemical obstructions.
Oh, wow.
Toxins, a thrombosis in the lungs like a massive PE,
Oh.
or a coronary thrombosis,
Right.
or pamponade, where fluid rapidly fills the pericardial sac around the heart. Tension pneumothorax, or trauma.
Let's look at the mechanics of one of those T's, tension pneumothorax. This is where air gets trapped inside the chest cavity outside the lung. With every breath, pressure builds up, and it eventually physically crushes the heart so it cannot expand to fill with blood.
It's terrifying.
In that scenario, you can perform textbook CPR for an hour, but until you provide the specific treatment, which is inserting a needle into the chest to release that trapped air, that heart will never restart.
The algorithm forces you to hunt for the root cause rather than just blindly treating the symptom of a stopped heart.
That concept of supportive versus specific care also applies to the arrhythmias that lead up to a code, right?
Oh, absolutely.
The nursing text details third-degree AV blocks, where the electrical signal from those pacemaker cells at the top of the heart is completely severed from the muscle cells at the bottom.
Yeah, that can be triggered by inflammation, a heart attack, or even beta blocker toxicity.
And the supported care is monitoring and stabilizing, but the specific definitive fix is often installing an artificial pacemaker to bypass the broken biological wiring.
Exactly. You stabilize the crisis, investigate the underlying pathophysiology, and implement the definitive fix.
Okay, so let's follow that trajectory. You successfully stabilize the patient, you run the algorithm, find the root cause, and the code blue ends. The crash cart is wheeled away, the adrenaline fades, and the reality of daily management sets in.
The daily grind.
Yeah, this is where the extern really earns their keep, mastering the daily pharmacology orders.
And cardiology pharmacology is incredibly dense. But the cheat sheets highlight the high-yield medications that really dictate the daily rhythm of the ward.
The first major class they emphasize are the ACE inhibitors, typically ending in pril, like lisinopril. They are foundational for managing blood pressure and heart failure.
Yep.
And the pharmacology source provides a brilliant memory hook here because the most common side effects literally spell out the word ACE.
I love that one.
A is for angioedema, which is rapid, dangerous swelling of the face and neck. C is for a dry, persistent cough. And E is for elevated potassium levels.
The cough is notoriously frustrating for patients, but the angioedema and elevated potassium are the clinical red flags you have to actively monitor on the ward.
Right. Another pillar of daily management are the beta blockers, ending in olol.
Yeah, and the major nursing consideration highlighted for beta blockers is orthostatic hypotension.
Because these drugs block the sympathetic nervous system from spiking the heart rate.
Right. Exactly. So when a patient suddenly stands up, their cardiovascular system can't constrict fast enough to fight gravity. The blood pools in their legs, their blood pressure plummets, and they pass out.
So the strict instruction is to educate the patient to sit on the edge of the bed and just dangle their legs for a few minutes before standing.
It is a super simple behavioral intervention that prevents a catastrophic fall on the ward.
Makes total sense.
Yeah.
Then we have the statins, the antihyperlipidemics. The cheat sheet is highly specific about statins. They should be administered before sleep.
Which is fascinating.
It is. When you look at the underlying mechanism, it makes perfect sense. Statins work by inhibiting the HMG-CoA reductase enzyme in the liver, and the liver synthesizes the vast majority of our internal cholesterol overnight while we are fasting and sleeping.
So you are timing the medication to hit exactly when the biological machinery is most active?
Exactly.
Yeah.
Though you also have to monitor the patient closely for rhabdomyolysis, a severe muscle breakdown that can overwhelm the kidneys.
Right. Another fascinating medication on the daily rotation is digoxin. The source stresses that digoxin has an exceptionally narrow therapeutic index, specifically between 0.5 and 2.0.
That margin for error is razor thin. I mean, the difference between a dose that helps the heart pump more efficiently and a toxic dose is microscopic.
And the presentation of digoxin toxicity is also bizarre. The text notes patients will experience profound vision changes, specifically xanthopsia.
Xanthopsia.
Yeah, where they start seeing yellow-green halos around lights.
That is so weird.
The mechanism there is wild. Digoxin works by inhibiting sodium-potassium pumps. When it reaches toxic levels, it doesn't just affect the heart. It crosses over and inhibits those same pumps in the optic nerve and the retina.
So it's literally altering how the photoreceptors process light.
Exactly. It's incredible how a cardiac medication manifests as a neurological visual disturbance.
Finally, we have aspirin.
Yeah.
Outside the hospital, it's a basic painkiller and antipyretic for fevers. But inside the cardiology ward, it is a critical clot prophylaxis.
Right. Permanently binding to platelets so they can't aggregate and cause a thrombosis.
The daily monitoring involves checking for occult bleeding, usually presenting as black tarry stools. Oh, and there's the cardinal rule of pediatrics here. Never give aspirin to a child recovering from a viral infection due to the risk of Ray's syndrome.
Mastering the mechanisms and side effects of those medications is like half the battle of the daily progress notes.
The other half, and perhaps the most complex part of daily ward management, involves fluids and electrolytes. The Extern 101 source has this massive highlighted warning about potassium management.
Oh, this is a big one.
They emphasize that before you ever order an IV potassium drip, you have to determine if the patient's low lab value is due to a potassium loss or a potassium shift.
And this is where medical students frequently get trapped. If a patient is on heavy loop diuretics and they are literally excreting massive amounts of potassium in their urine, that is a true total body loss.
The tank is empty.
The tank is empty, and you must replace it by ordering potassium supplements.
But the shift is entirely different. Sometimes during severe acidosis or when specific medications like insulin are administered, the potassium hasn't left the patient's body at all.
Right.
The chemical environment has simply forced the potassium to hide out. It shifts out of the bloodstream and into the intracellular fluid.
So the total body potassium is perfectly normal, but the blood test looks dangerously low.
So if you act like a technician and just blindly look at the low number on the lab report and aggressively push IV potassium to fix the number, what happens when you fix the underlying acidosis?
Well, the moment the body chemistry normalizes, all that hidden intracellular potassium shifts rapidly back into the bloodstream, joining the massive IV dose you just pumped in. You have instantly induced severe hyperkalemia.
And if we look back at our 6H code blue algorithm, hyperkalemia is a primary trigger for cardiac arrest. Attempting to fix a number without understanding the underlying cellular mechanism can literally kill the patient.
This is precisely why the survival guides hammer home the importance of meticulously tracking a patient's I/O, their input and output. You cannot distinguish between a shift and a loss unless you know exactly how much fluid and electrolyte volume went into the patient and precisely how much was excreted.
Okay, so mastering the vocabulary, memorizing the 6H diagnostic algorithm, understanding why statins are given at night, and tracking the I/O. That covers the hard science of the rotation.
Yeah.
But surviving the ward and ultimately evolving into a competent physician relies heavily on the art of medicine.
The humanistic soft skills.
Exactly. The Extern 101 guide spends a significant amount of time on this. It notes that physical exams in cardiology require utilizing multiple senses. You are not just listening for murmurs with a stethoscope.
Right. You are palpating for pitting edema in the legs, feeling the amplitude of the peripheral pulses, and observing the distension of the jugular vein.
Interestingly, they point out that percussion, like tapping on the chest, is largely skipped in modern cardiovascular exams because echocardiograms provide far superior imaging.
Yeah, technology has taken over that part.
But the most profound insight in the guide focuses on the unique advantage of being an extern. You do not have the vast clinical experience of the senior attending, obviously, but you have the one resource they are completely devoid of, which is time.
Time. The attendings are orchestrating the care for dozens of patients, battling bureaucratic paperwork, performing procedures. They are sprinting from room to room.
But the extern can actually pull up a chair and sit at the bedside. You have the time to take a meticulous, unhurried history. You can unravel the tangled web of a patient's comorbidities.
Which is so common. A patient in the CCU rarely just has heart failure. They have concurrent diabetes, advancing kidney disease, complex social barriers to obtaining their medications.
And that bedside time is where you catch the critical details that the electronic medical record just misses. It is where you transition from being a student, memorizing pathways, to a clinician treating a human being.
Well said.
The sources also provide highly actionable survival tactics. Cardiology is a relentlessly research-driven field. The guidelines you memorize on a Monday might be updated by clinical trial data on a Friday.
It moves so fast.
So fast. The absolute best advice is to download the clinical guidelines, like the Comprehensive Thai-Heart Association PDF, directly to your phone so they are instantly accessible during rounds.
And use the rotation to network with the fellows. Volunteer for case reports or research projects.
And regarding the pressure of knowing when a patient is ready for discharge, the criteria is elegantly simple. Patients go home when there are no longer medical indications requiring them to stay in the hospital.
Right. Keep it simple.
But reading through the Extern 101 source, you can really feel the immense psychological weight placed on medical students. The guide explicitly acknowledges this environment, stating, "Medicine is not kind to us, so we have to be kind to ourselves."
That might be the most vital piece of literature in all the sources. Medicine has cultivated a culture of toxic perfectionism, but you are inherently fallible.
You're human.
Right. You are going to write a progress order under the wrong AN. You are going to misinterpret an NSTE ACS on an ECG.
And when it happens, the impulse is to spiral into imposter syndrome.
It is deeply uncomfortable. But your medical knowledge is only valuable when applied with compassion, both toward the patient and toward your own learning process.
Absolutely.
The objective of your rotation is not flawless execution on day one. The objective is building the architecture to course correct. You acknowledge the misstep, you dissect the underlying mechanism of the error, and you systematically ensure you never make that specific mistake again.
Expertise is built on a mountain of analyzed errors.
Beautifully put.
We have covered a massive amount of ground today. We started by decoding the alphabet soup of hospital geography and the vital importance of the 50 must-know vocabulary terms and patient identifiers.
Mm-hmm.
We broke down the critical 10-minute ECG window and how moving the leads to the right ventricle alters the entire pharmacological strategy. We moved from the supportive CPR of a code blue into the specific diagnostics of the 6 H's and 6 T's. We explored the cellular mechanisms of our daily pharmacy orders, from digoxin halos to nocturnal statins, and finally, we examined the soft skills and self-compassion required to survive the ward.
It is a phenomenal amount of data, but every single concept connects back to the singular objective, keeping the biological machinery of the heart pumping efficiently.
It does. But I want to leave you with a final thought to ponder as you prepare to step onto the hospital floor. Cardiology is arguably the fastest evolving specialty in medicine, driven by massive clinical trials and rapid technological innovation.
True.
The standard of care we just discussed, the precise therapeutic windows, the medication algorithms, it was likely considered experimental or even controversial just a decade or two ago.
But for sure.
So as you diligently memorize these absolute, undeniable rules to survive your clinical rotation today, ask yourself which of these foundational medical facts will be completely obsolete by the time you become a senior attending.
It really is a humbling reminder of how transient medical knowledge can be.
Stay fiercely curious, keep those clinical guidelines bookmarked on your phone, and continue diving deep into both the hard science and the human art of medicine. Next time you walk onto that ward and the monitors start beeping, take a breath. You know the language now. You've got this.